So as far as chronic pain is concerned, there are few ankle and foot entities. I mean, like there are few disease entities in ankle and foot that we treat very regularly. Okay, so to understand that, first we start from the anatomy part. Then we will go in the sonoanatomy, and then we will go to the common diseases. Okay, not all the diseases of ankle and foot, only the common diseases. So let us first understand what is the anatomical structure. So here these are the tarsal bones. So if we see our foot, we have to divide them in three parts. Okay. So first part, this is the hind foot. So, this part is the hind foot. Okay. And then this part is the mid foot, and then apart from that, this part is the forefoot. Okay. So how this hind foot is formed? Hind foot is formed by two tarsal bones. One is talus and one is calcaneum. So this one is talus and this one is calcaneum. So remember in this way that just in front of talus, the bone which is there, that is the navicular bone. And in front of calcaneum, the bone which is there, it is called cuboid. Okay, when these two bones, when they are forming the ankle or foot part, hind foot part, so these four bones are not at the same level. You think in this way that this talus and navicular bone is at the upper level. So maybe we can consider in this way that talus and navicular forms a first floor of a building, and calcaneum and cuboid makes the ground floor of the building. So from going from ground floor to first floor, there are three stairs. And what are the three stairs? So these are the cuneiform bones. So these are the three stairs. Okay, so in this way we can remember all the bones. So whenever we under ultrasound, we will see that we will focus at the talus. So we will know that just in front of the talus bone, the bone which we can find, this is the simply navicular bone. So if our probe is directed towards the first great toe, towards the great toe, then what bones we will be seeing? We will be seeing the talus, we will be seeing the navicular, and we will be seeing the first cuneiform bone. Our probe will be if we place like that, then just in place of the first cuneiform, it will be second cuneiform, and in the third finger, third toe, we will be seeing the third cuneiform. So here there are two bones which have the maximum number of attachments. One is cuboid and one is navicular. Navicular also joins with 1, 2, 3, 4 and fifth bone. So with 5 bones, okay, it has attachment with the 5 bones. Similarly, cuboid also has attachment with the 5 bones. One is 1, 2, 3, 4 and the fifth bone. So all these bones are attached to the cuboid also. So from there, now we are going to the, so this is the bony anatomy, first part, and then we are going to the, so you see that upper part of the bone, if we just consider the upper part of the talus bone, where what is connected, what is attached there to form the joint, so that is the tibia and fibula. So here if we talk about the joint recess, then tibiotalar joint forms the anterior joint recess and posterior joint recess. So what is the recess? And recess means the synovial sac, the synovial capsule of the joint. Its attachment does not necessarily just include the joint part. Okay, so it includes a bit more part rather than the joint. So you can see that this is attaching at this point and this capsule is joining on the talus at this point. So this area is called recess. Recess is very important in our all interventions, because most of the time while injecting in a joint, we are not putting a needle in between the bones. We are always targeting a recess. So be it in a shoulder joint or in a knee joint, in most of the areas, the recess is the area where we inject. And actually, this is the area where we always see for any effusion if we suspect a arthritis. So tibiotalar joint recess, we will search if we suspect tibiotalar joint arthritis. So how many recesses are there? There are two recesses. One is anterior joint recess, one is posterior joint recess. Second thing, there is a subtalar joint also. So this is just below, as the name suggests. So this is the subtalar joint. So subtalar joint also we can see during our ultrasound examination. So there also fluid can accumulate. So this tibiotalar joint and subtalar joint, sometimes they have connection, but not every time. So either they can be continuous also, and effusion can be present in both, or you can see the fluid or effusion in only tibiotalar joint but not in the subtalar joint. So now, as we understand that foot and in ankle and foot pain, so where from the pain is coming? So pain comes from the structures which is there in our body only. So it can come from the joint, it can come from the ligaments. Now ligaments, remember, ligament is also a very deep structure, because ultimately it connects from bone to bone. So it is just above the joint level, or sometimes the ligaments are nothing but the thickening of the capsule. So it is just a part of the capsule. So here we are talking about ligaments. So there are multiple ligaments in the foot, but we will talk only the important ligaments which are there, I mean, like, which usually causes the which is usually the reason of the ankle joint pain. So now, if we talk about the lateral ligaments, so remember, lateral ligaments all starts from the fibula. So this is the fibula bone. Okay. So what, as I told you, the why the bony anatomy is important. So since this part is tibia and fibula, then we know it all connects with the dome of the talus. So this bone must be the talus. Okay, this bone must be the talus. So, and this bone must be the calcaneum. This bone must be the calcaneum. So from fibula, if we think what are the ligaments are there, so this ligament is calcaneofibular ligament. So fibula to calcaneum, calcaneofibular ligament. And then another ligament is there, that is fibula to talus. So this is talofibular ligament. Of course, talofibular ligament can be anterior also and can be posterior also. Another ligament is from tibia to fibula. So this is the tibiofibular ligament, and similarly this also can be anterior tibiofibular and posterior tibiofibular ligament. So all these ligaments actually can be is prone to injury anytime. Mainly it is due to the sports injury. When the very common type of sports injury is tibiofibular ligament rupture. Okay, but then this is the lateral ligament. So remember, if you can remember, that all starts from the fibula. So you remember that what actually are the things which starts from the fibula. I mean the lateral, the adjacent structures. So just one adjacent structure is talus, one adjacent structure is calcaneum, and one is tibia. So tibiofibular, calcaneofibular, talofibular. That's it. Okay, I think. Okay, now another.
Money.
Oh. Dr. Pavan Kumar, please remain muted. Okay. So anyway, as I talked about the lateral ligaments, similarly, there is medial ligaments also. Now, remember, it is this is the common injury, is sprain injury. Whenever someone is playing or doing some work, and due to the sprain or due to the wrong position of our ankle, these ligaments rupture or at least get injured. So there are two types of movement can occur. One is inversion, and one is eversion. If inversion occurs, then lateral ligaments are prone to rupture or tear. And if it is an eversion of foot, then medial ligaments are prone to injury. So what are the medial ligaments? Remember, medial ligaments have four slips. Okay, four parts, you can say. So what are the four slips? So understand, as the lateral ligaments start from fibula, medial ligament starts from tibia. So from tibia to talus, you can understand this is talus. So just under the tibia or fibula, the next bone, as soon as it's the next bone is the tarsal bone, is the talus. This much you should remember. Okay, so tibia to talus. Then comes tibia. So this is the tibio-talar ligament. Then comes tibius to calcaneum. So this is the tibio-calcaneal ligament. Then comes another two ligaments. So one ligament we can understand that this bone is talus. So this one was navicular. Okay, so this is tibio-navicular ligament. Here one ligament is there which is starts from bone but ends in another ligament. So this red color ligament is actually spring ligament. This is called spring ligament. So this ligament, this part is tibio-spring ligament. So remember, deltoid side, medial ligaments have four slips. One is tibio-talar ligament, one is tibio-calcaneal ligament, one is tibio-spring ligament, and one is tibio-navicular ligament. Of course, spring ligament is not a ligament of the medial side. This is of the foot. This is the inferior side of the ankle. So this is a better to be called as a foot ligament. Okay. So just understand this much. What are the ligament names? So one important here in the lateral side, one important ligament is ATFL, anterior talofibular ligament. So remember, this ligament is the commonest ligament to be injured. If we compare both and medial side and lateral side, ATFL injury is the commonest cause of sprain, and it is from the talo to fibula, talus to fibula, and lateral side. So this information will be required later. Now comes, there are some other ligaments which are actually plantar ligaments. So if these ligaments are ruptured or injured, then someone will have foot pain, sole pain. It is from the inferior side, so sole pain. So it has two types of plantar ligament: short plantar ligament or long plantar ligament. You can see this one is the long plantar ligament, and this one is the short plantar ligament. But of course, this is not that important, just to tell you. So now we go to the muscle or tendon of the ankle. So what are the muscles and tendon of the ankle? So remember, any tendon can cause tendinopathy. Any tendon can rupture. Okay, so due to the injury or sports related injury only, mainly this tendinopathy or tendon rupture occurs. And tendons can, we can have tendinitis also. So just we have to remember that which compartment or which tendon is found where. So first thing, think about this person, that this person is standing like this, and we are seeing a cross section at the cuff area in both sides. So this is his right side and this is his left side. Okay, so now understand the compartments. So between tibia and fibula, fibula is lateral side, so there is a compartment. So this compartment is called anterior compartment. Between fibula and just above the fibula, actually not between fibula, above the fibula, there is one compartment that is called peroneal compartment, peroneal or lateral compartment. So remember, anterior compartment, peroneal compartment, and there is a third compartment that is in the rest of all the muscles are there. So that is the posterior compartment. Now posterior compartment has been made a superficial posterior compartment. So this one is superficial posterior compartment, only this much, and one part is deep posterior compartment. Okay, so only the two muscles which forms the Achilles tendon, mainly, that are formed by the gastrocnemius and soleus. Achilles tendon is formed by gastrocnemius and soleus, that comes from this superficial posterior compartment. This much you can remember very easily. Now peroneal compartment is having the tendon which is the peroneus longus and brevis. Only one important thing here is peroneus brevis is near to the bone, near to the fibula. This much you can remember, that B for bone, B for brevis. So this is the brevis muscle, and even the tendon also always closer to the fibula, bone, and not the peroneus longus. So okay, these two tendons, these two muscles and tendons are there in the peroneus compartment, peroneus longus brevis. In posterior compartment, as I said, it is gastrocnemius and soleus. Okay, now comes anterior compartment and this deep posterior compartment. So these deep posterior compartment muscles, they form the tendons in the medial side. So these comes to the medial side. They do not remain when they cross ankle. When they cross ankle, they do not remain in the posterior side. They become tendon and come to the medial side. Okay. So this deep posterior compartment forms the medial tendons, and this anterior compartment always remains in the anterior side and forms the extensor tendons, ankle extensors. When they come in the anterior side, if they contract, they will become the anterior extensor. Now, just understand this one. So this one. So as I told, deep posterior will come to the medial side. So here just see the three tendons are there in the medial side. They are actually the deep posterior compartment muscles or tendons. So just remember Tom, Dick, Harry. We start from medial malleolus. Okay. So from medial, this is medial malleolus. We start from Tom, Dick, Harry. So this is mnemonic only. So Tom means tibialis posterior. So this one is tibialis posterior. Then comes second thing is Dick. So this one is the digitorum. Digitorum, and this is the flexor compartment. So flexor digitorum, and of course this is longus. So this is the flexor digitorum longus. Okay, so this one is flexor digitorum longus. Then comes hairy. So means flexor hallucis longus. Okay, so this one is flexor hallucis longus. So remember this mnemonic, and you can remember all the three tendons in the medial side. Tom, Dick, Harry. So this is the tibialis posterior, and this is the D for your flexor digitorum longus, and then flexor hallucis longus. Remember, all the neurovascular bundle is between second and third. So digitorum longus, and between digitorum and hallucis longus, there is the neurovascular bundle. So what nerve and what vessel? So one is posterior tibial nerve, and the posterior tibial vessels are there between second and third tendon. Okay. So anterior side, just I showed you this picture, that this anterior, all the anterior compartment muscles will come to the anterior compartment, anterior side of the ankle, become tendon and come to the anterior side of the ankle. And if they contract, it will cause extension of the ankle. So here you see that what is there in the anterior side. So now also, just to remember this, you start from medial malleolus only. Okay, but this time it is Tom, Harry, Dick. It is not Tom, Dick, Harry. It is Tom, Harry, Dick. So what are the muscles here? So remember, that side was tibialis posterior. This side it is tibialis anterior, and Harry means hallux. So this tendon is coming to the hallucis. So extensor hallucis longus tendon, and another is D for digitorum. So this is digitorum. So this is extensor digitorum longus tendon. Here also between second and third. So between second and third, you will get all types of neurovascular bundle. So at this point, what neurovascular you will find? That is the anterior tibial nerve and anterior tibial artery and vein. Okay. So just remember, both mnemonics start from medial malleolus. Anterior side it is Tom, Harry, Dick, and this side, medial side, Tom, Dick, Harry. That's it. Lateral and posterior side is very easy. So lateral side peroneus longus brevis, and posterior side is gastrocnemius soleus. Of course, between gastrocnemius and soleus there is another tendon, that is plantaris, but we don't need that. Okay, there are some other thing, that is retinaculum of foot. So these retinaculum of foots also can cause entrapment neuropathy of these nerves. Anterior tibial nerve can be entrapment neuropathy of anterior tibial nerve can be a cause, can be caused by the superior extensor retinaculum, tight extensor retinaculum. So this is the extensor retinaculum. So just to I mean tell you that what are the nerves that are there around the tendon. So we have already read that medial side there is this one, your posterior tibial nerve, but along with that there is another nerve, that is the Cephalus nerve. Okay, so posterior tibial nerve and Cephalus nerve is in the medial side. What is the in the lateral side? What nerves are there? So there is superficial peroneal nerve and sural nerve. These two nerves actually, superficial peroneal nerve and sural nerve, these are in the lateral side, and Cephalus nerve and posterior tibial nerve is in the medial side. Anterior side, it is always the deep peroneal nerve or anterior tibial nerve. It is the same thing. Okay, same nerve. We can call it as anterior tibial or deep peroneal. Okay, so total 5 nerves are there around the ankle to supply the ankle joint. So how they will, so just for understanding purpose, when patient will come with some entrapment neuropathy of the of these nerves, then how the patient will present. So you can see just lateral side, it is supplied by the mainly the superficial peroneal nerve. Anterior medial side, it is supplied by the Cephalus nerve. So Cephalus nerve, medial side, superficial peroneal, lateral side, and the plantar side is actually plantar nerve, medial nerve, lateral plantar nerve. These are actually branches of posterior tibial nerve. Okay, only the first wave space is supplied by deep peroneal nerve. This nerve is or anterior tibial nerve found in the anterior side of the ankle. There are some bursa. So premalleolar bursa, so this is called lateral premalleolar bursitis. This bursitis is on the subcutaneous level, lateral premalleolar bursitis. Another is medial, so same thing can happen in the medial side also, medial premalleolar bursitis. And the most important bursa here is in the ankle area, that is the retrocalcaneal bursa. So this is the deep retrocalcaneal bursa. And one subcutaneous calcaneal bursa also it is there, superficial calcaneal bursitis, but deep bursa, this is deep to the calcaneal Achilles tendon. Deep to the Achilles tendon, this bursa is retrocalcaneal bursa. So this is the commonest bursitis found in the ankle area. Okay, retrocalcaneal bursitis. So, as I told you that we will describe about the common diagnosis. So, what are the common diagnosis? First thing is ankle joint arthritis. We can understand that which is the ankle joint actually. Actually, it is between tibia or fibula and talus. So, tibia and talus. So, this tibiotalar joint is mainly considered as ankle joint arthritis. Though other joints also can get affected, but then tibiotalar joint is the, when we say ankle joint arthritis, we mean tibiotalar joint arthritis. Then comes ankle sprain. As I told you, so many ligaments are there. Commonest ligament tear is ATFL, anterior talofibular ligament tear. Okay. Remember, posterior also talofibular ligament is there, but that is not common cause of sprain. ATFL tear. Then comes Achilles tendinosis. So Achilles tendon problem, it can be tendinosis, it can be tendinitis, or it can be acute tear of the myotendinous junction of the Achilles tendon. So here Achilles tendinopathy can be a combined term for all these things. Then comes retrocalcaneal bursitis. So I told you, among all bursitis, retrocalcaneal bursitis is common, and mostly it is found with Achilles tendinitis or tendinosis. Then comes plantar fasciitis. So plantar fasciitis, it causes the foot pain. So where is the plantar fascia remaining? So it is in the foot. I will tell you, show you later. So then comes tarsal tunnel syndrome. So tarsal tunnel syndrome is not that common, of course, but sometimes we can find tarsal tunnel, I mean posterior tibial nerve neuralgia, and mainly tarsal tunnel syndrome means this is like a carpal tunnel syndrome only under the flexor retinaculum, under the medial side of the ankle. When the posterior tibial nerve is passing through, so there is entrapment. So this can be it is not that common, but sometimes we can find the tarsal tunnel syndrome patient also. So symptoms of first, let us talk about the arthritis, which is the most common cause of ankle pain. So remember, in arthritis, as we know, there are two types of arthritis. One is degenerative cause and one is inflammatory cause. Remember, ankle joint is one of the arthritis when if patient comes with ankle joint pain and under ultrasound you see effusion and all, then you must think of inflammatory arthritis until otherwise proved. Okay, like if someone comes with hip joint arthritis or knee joint arthritis, you first think of degenerative and not the inflammatory. But ankle and elbow, these two joints are important to think that this case must be an inflammatory arthritis and not degenerative. Okay. So what are the symptoms? One is pain, gait abnormalities, swelling, and then stiffness. So as I told you, stiffness is common as it is the inflammatory arthritis is common. So morning stiffness is also very common. Then comes crepitus. So grinding or crackling sensation due to cartilage degeneration. So first arthritis starts after few days the degeneration occurs of the joint and crackling can start. Then instability, a feeling of ankle giving way. Then morning stiffness and deformity. So all these things can happen in ankle joint arthritis. Of course, these are not specific to ankle joint arthritis. In any type of arthritis, you can get these symptoms. Now, this is the ankle anterior recess of the ankle joint. So, as I showed you the picture, and anterior recess and posterior recess, both recesses we can see. So, here in this picture, this side is tibia, this side is tibia, and this side is talus. So, talus is actually this whole bone is talus. Okay. So, this part is actually this part is head or dome of talus anyway, and this part is neck. uh, no, sorry, this part is uh, dome of talus, this part is dome of talus, this is neck, this is head. Okay, so this area is anterior tibiotalar, anterior joint recess. Okay, and the fluid can accumulate in both the areas, over this area also, over this area also. At present, in this area, it is the loose areolar tissue or fat is there. But if there is fluid, then it will be displaced by anechoic effusion. Okay, and here we can see another joint. This is between the talus and navicular bone. So this is between the talus and talonavicular joint area. So you can see that fluid is there. So if fluid is collected, then the loose areolar tissue will be pushed upward, and we can see the effusion in the recess. So this is the anterior recess of tibiotalar joint. So this is tibial spar projecting in the anterior recess. So this is the tibial spar. So sometimes whenever you are seeing an arthritis, you will of course see that whether there is effusion, whether the joint margins are normal or there is some irregularity in the margin, if there is osteophyte formed or there is spar is formed, or and also in the effusion you will think that whether there is synovial hypertrophy or not. So these things are common, and we will see in each arthritis. Okay. talonavicular joint arthritis. So we saw the tibio-talar joint. After that, distally if we go, then talus is connected or to with the navicular bone. So here we can see this is the effusion at the talonavicular joint, and we can see small osteophytes also. So these are osteophytes and these are effusion. Of course, when you put the Doppler ultrasound here, you will see the Doppler activity around the joints. So posterior tibiotalar joint recess, I told you that we can see the tibiotalar joint from anterior also, posterior also. And this assessment is for seeing the arthritis of this joint. We will see if the effusion is there, we will see the joint margins are normal or not. So here we are seeing from medial side. So this is the tibiotalar joint. So here also these tendons in the medial side, Tom, Dick, Harry, you understand? So either D or H, like flexor hallucis longus or flexor digitorum longus, both can be seen here while seeing the posterior joint recess of the tibiotalar joint. Okay, so these are the tendons. So same thing, subtalar joint, we can see the subtalar joint also. So just below the talus, what another bone is there? So it is the calcaneum. So these are the subtalar joint area. Okay, so here also we will see that whether effusion is there or not. Likewise, we can see this joint from lateral side also. Anterior side, medial side, and lateral side. Mane posterolateral, posteromedial. So this is the posterolateral side we are seeing. So here also we can see the joint tibiotalar and subtalar both, and we can see a lot of effusion in the lower picture. Actually, it is not fully seen, but it is the effusion you can see. So interventional treatments for any joint, for any arthritis. What are the interventions needed? So interventions needed are corticosteroid injection if it is an acute presentation, or there is no acute inflammation but there is a deformity and chronic pain. Then we will go for the hyaluronic acid injection. Regenerative therapy options are also there. Then we will go for the PRP injection, or other regenerative options are there. Okay. Now I go to the before demonstration. So I go to the first to the sprain, ankle sprain. So as I told you that commonest sprain is in the lateral side. So this is the inversion injury, inversion movement of the ankle, and since it is too much, so there is an injury of the lateral side. And lateral side anterior talofibular ligament is the common ligament ruptured, ATFL tear. So how patient will present to you? Usually this patient always presents as a acute pain, but some patient can come with a mild degree of pain continuing for say 6 months, because there was a rupture and then acute inflammation has healed, but rupture continues. Maybe partial tear continues, and that's why patient's pain also continues. So lateral ankle pain and swelling, bruising, ecchymosis, if it is appearing within 24 to 48 hours, so patient comes to you acutely, then only you will see bruising. Then instability, since it is a ligament tear, difficulty bearing weight, tenderness over the ATFL region. So this is also very common, that you have to see by ultrasound that where is the location of the ATFL. Press there and you will see tenderness, limited range of motion, and positive anterior drawer test. So it is like increased forward translation of the talus relative to the tibia, suggests ATFL laxity or rupture. So this is also seen by the while examining. Now ATFL injury. So this will be demonstrated by Dr. Devjyoti. So here let us see two bones. This is fibula and this is talus. So in this area, you will find this is the ligament. Okay, this is the ATFL ligament. Any question? Any question? No. Okay, so ATFL from fibula only. So this side is fibula and this side is talus, and this ligament is the normal ligament. Okay, this is the normal ligament ATFL. But if it is ruptured, you will see there is no, I mean, you cannot find the ligament. The fibrillar structure, this is hyperechoic and fibrillar structure. This is a partial tear, only this area is affected. Okay, so this area you can see some detachment is there and some fluid accumulation is there. Normally it is from bone to bone hyperechoic fibrillar structure. Okay. So for all types of ligament injury, the main ATFL injury, if patient comes to you, it is the price protocol. So protection, rest, ice, compression, elevation. Remember, it is for acute injury. For acute injury, this is the price protocol is followed by everyone. So let us go for demonstration of the joint and ATFL. Just a minute.
Hello.
Is anyone have any question? Devjyoti, are you there?
Yes, I am here.
Okay.
So let me start with ATFL first.
Yes, yes.
Okay. So let's share. So we'll be going with the step-by-step approach for the ATFL. Remember, it is the ligament that is most commonly affected. So we need to know at least about this ligament in a very good way. Okay. So somehow it's not full screen. Are you able to see it full screen or not?
No, no, no.
Just 1 second. View full screen. No, it is coming still small. Anyway, it is visible clearly, I think. So we can continue with it. So let's start with the step-by-step guide for the finding out the ATFL. So two ligaments important. One is ATFL and one is the AITFL. So most important is the ATFL because that is the ligament that is most commonly affected. So let's start our scanning from this bone. Can you see this? This is the fibula. So if you put the probe just above the fibula, we'll be able to see this structure. Just 1 second, let me unfreeze. So over the fibula, there is a specific look which is known as the shark fin appearance. So we can see the shark fin appearance of the fibula. Now, what are the important structures just posterior to this? So immediately posterior to this, we have two muscles. This is the one by one I am showing. Just 1 second, settings, and then scribble. Okay, so I'm just taking it over one muscle. So this one is the peroneus longus, and this muscle is the peroneus brevis. So as I come anteriorly, so keeping the peroneus longus and brevis towards the right side, or you can say posterior side, let me increase the gain slightly because otherwise. So here we can see the peroneus longus and brevis remaining at the posterior side, and the shark fin appearance you can see. Just going to the anterior side, we can see another bone. So what is this bone? This bone is obviously the fibula, but what is this bone? Can anyone tell at this point what could be the bone here?
Calcaneus.
Yes?
Calcaneus.
No,
Tibia.
it's calcaneus. See,
Talus.
where I
Talus.
am handing.
Tibias.
Calcaneus is here.
Tibia.
Tibia. Definitely, the bone here is tibia. So first we need to follow the gap between the tibia and fibula, and we have to find out where the tibia ends. See, at this point, fibula is still there, but tibia is ending. As we go further, then we'll be able to see another structure, which is actually a pyramid shaped structure with cartilage over it. So what is this bone? Under the tibia, what is this bone?
Talus.
Talus.
So two ligaments mainly remains at this point. One is the anterior inferior tibiotalar ligament. Remember, it can be injured, but it is a tough ligament, and when it is injured, it is mostly associated with some bony deformity as well. But we'll be seeing both the ligaments because for understanding it will be easier. So let me go back to this point where we are actually the tibia is ending and fibula. Now I am doing a little bit trick here. I am keeping the fibular point intact. Okay, I am fanning it slightly over. Okay, so that we start seeing the which bone? Tibia again. So here for this volunteer, the size is very small because the leg is also very small. So in between these two bones at the lower end, we can see a ligament. Remember, it is not a horizontal ligament. You can see how we have put the probe. We have put it slightly obliquely, and in between the tibia and in between the fibula, we see this ligament. Okay. Let's take the pen and draw it for you. So this is the upper margin of the ligament. Here lies the lower margin of the ligament. So you can see it's a large ligament, and this ligament is a very strong ligament. This is the AITFL. That means the anterior inferior tibiofibular ligament. So we have understood how to find out the anterior inferior tibiofibular ligament. Remember, the injury of this ligament is comparatively rare because it's a very strong ligament and it forms the part of the mortise. Now, again, I am going back the steps one by one. So follow this shark fin shape. So you can see the shark fin of the fibula. Here towards the posterior side, we can see the peroneus longus and brevis. Go to the anterior side and find out the mainly the peroneus tarsus and the flexor digitorum, and then we go down, 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 where it ends, okay, where the tibia ends, and once the tibia ends, we start seeing one triangular muscle. This muscle is the talus. Now keep hold the lateral part on the fibula and rotate the medial part, sorry, not the medial part, anterior part, I should say, it is correct, over the tibia again, and then the ligament in between these two bones, what we get is the anterior inferior tibiofibular ligament. But let's come to the most important ligament, that is the ATFL. Keep the probe there. Only again start fanning, keeping the posterior part over the fibula. Try to put the anterior part 90° from the previous angle. So what will happen? Again from here, from tibia, will be shift over to the talus, and as I go more towards 90°, so we start seeing another ligament. Okay, let me do one thing. We need to put a little bit more gel because already with so much movement the gel is reduced. Again, I am holding it in the same fashion so that it is easier for you. From the previous ligament, let us move 90°. So first we will starting the again the triangle of the tibia, and next we will start seeing another ligament. And everyone see this ligament? To stretch it, let us put a little bit pressure, and here we can see the clear ligament between these two bones. Okay, so those who are not able to see it properly, I am trying to make it more clear. Actually, in ankle, we need to put a lot of gel for maintaining proper angulations. Otherwise, there are too many ups and downs. Okay, Now you can see the ligament in between these two bones. Okay, let me stretch it a little more. So this is the ATFL. Okay, let me stop and let me draw it. A little bit anisotrophy towards the fibula is there, but here if you look at the whole part of ligament is here. Okay, the whole part of ligament is here, which is connecting. Remember, there are no muscles in the talus. Sorry, and it came. There are no muscles in the talus, so only the ligaments are attached to the talus. Fortunately, okay. So there are no muscles in the talus, but here we can see this ligament. So this ligament is the anterior talofibular ligament. So you can see the probe angulation. So it is slightly say horizontal or slightly below the horizontal where you can see the best. Okay. So I am now the live scanning. So we can see now you are able to appreciate it, everyone, or I need to increase the gain slightly. Just 1 second. Okay. So now you are able to appreciate. Now with this
Yes,
gain,
sir.
it's seen beautifully. So
Yes.
now look for a little up and down. So in presence of any injury or there is nearby edema, because remember when we get an ankle injury in most of the patients, okay, especially if it is an inversion injury, what happens? The most commonly this ligament is torn. Okay, even one of my ATFL is torn. Okay, so it is not partial, not a total tear, but it's a partial tear that injury I got long back. But remember, sometimes it can be painful for a very long duration. Okay, so what are the treatment options? First, in acute injuries, you have to go for the NSAIDs, rest, sometimes immobilization, but not entire immobilization is required. If it is responding, well and good. If it is not responding, which becomes subacute, nowadays we go for the platelet-rich plasma injection within this ligament. So under this vision, you have to go in an out of plane approach, because in this ligament actually there are two bones in both the sides, so sometimes it becomes very difficult to approach just by the in plane. Okay, so ATFL, you have understood all the steps, or should I repeat one by one? I have repeated. So just the last part, first come from the fibula, go here, and first try to figure out the AITFL, then go and just rotate, just follow. I am just doing the other hand. I am just rotating it like this. Okay, I am rotating it like this. But remember, you don't miss out the fibula. So one side you should keep it fixed at the fibula, then only you will get the other over the talus. So this will be the anterior talofibular ligament. Clear? Any questions?
Sir, in what position is the patient lying down, sir? Prone with knee flexed.
No. See, I'm just showing the patient.
Lateral. Okay, sir.
Lateral like this. Okay.
Okay, sir. Thank you, sir.
So Dr. Royal will continue with the other portions.
Okay. So I think you can see the ultrasound, I mean screen, no? Volunteer and ultrasound part.
Yes, sir.
Okay. Now I am showing you the other parts. Okay. 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 So left side is cranial side. Okay. So we are seeing here. So Left side is cranial side. Here actually there is one small problem in the probe, so don't consider it. I mean, just ignore this. Okay, this side is tibia. What is this? Anyone can tell? Dome of the talus.
Talus, yeah.
Yeah. This part is neck. This part is head. Okay. So what is this part? Anyone can say what is this part?
Anterior recess.
Yes, this is the anterior recess. So again, just see. So we can see the anterior recess and fat. These are all fat. So if there is a fluid collection, this fat will be moved up. Now we can see. So I'm going towards the great toe. So what is this joint? Anyone can say?
Talonavicular joint.
Yes, this is the talonavicular joint. Okay. And of course, this is the cuneiform, and then comes the metacarpal. So we don't need that much. Okay. So this is the anterior joint recess. Now I will show you the. So I hope you all have understood that ATFL. ATFL actually it is not seen by not seen well by this probe. Usually you need a very high frequency probe. Okay, so Dr. Devjyoti has shown it. So here actually 3 steps. Just in this way we can put by tibia and fibula. Then we will put one side fixed on the fibula and another side on talus. Okay, and then just go a bit below. You will see the ATFL. Okay, so 3 steps. Anyway, this has been shown. So I show you the posterior side, posterior recess. Please. So posterior joint recess. Okay, so I'm showing you the medial side, from the medial side. So see. So which bone is this? This bone? This bone?
Tibia.
Tibia.
Fibulus.
Medial side, medial side.
Tibia.
So this is the tibia, and this is the posterior joint recess, tibio-talar joint. Okay, if I go down, then of course I will see here also we can see the calcaneum. So this part is calcaneum, and this part is so for seeing tibio-talar joint posterior recess, we see this part, and this part is actually subtalar joint. This is the subtalar joint area. Okay. Now I show you the from the lateral side. So in findings are similar in every side. So this is also in the lateral side. So this is the tibio-talar joint area. This is the tibio-talar joint area. Okay, and of course this is the talocalcaneal joint area, talus and calcaneum. So but then when we see the posterior joint recess, so here also we can find if there is too much fluid, so in the lateral side tibio-talar joint, but mostly for seeing the posterior joint recess we will see from the medial side, this side, for seeing the posterior joint recess. And these tendons are what tendons I told you? It can be which tendon?
Flexor tendons.
Flexor hallucis longus or flexor
Flexor
digitorum
digitorum.
longus. These two. Okay. So this much, this is the joint part and ligament ATFL we showed. Now let me show you the other parts. Okay, so this much we showed. Okay, now comes Achilles tendinosis. So as I told you, Achilles tendon is formed by gastrocnemius and soleus. So Achilles tendinosis symptoms, what can happen? So gradual onset of pain. Of course, you cannot say every time it is a gradual onset. If there is a acute injury, then it will be acute onset. But if it is a degenerative symptom, which is most common, tendinosis, it is a degeneration. So then it will be gradual onset of pain. And where we will feel the pain? It is in the posterior ankle or lower calf, and it will be worsened by activity. Tenderness, pain on palpation along the Achilles tendon, especially 2 to 6 centimeter above the calcaneal insertion. So this is called mid portion tendinosis. Okay. So remember, the Achilles tendon usually have three problems. One at the insertion, one at the 2 to 6 centimeter above the calcaneal insertion, and that is always degenerative. So that is called tendinosis. Then morning stiffness, swelling or thickening of the area of the ankle, and pain with activity, crepitus, reduced strength and function, altered gait, all these things can be there. Now, as I told you, there's three areas we have to see. One is the insertion. So insertion is enthesitis, calcific tendinitis. So insertional tendinopathy or insertional tendinitis can occur at the insertion. And the most common is degenerative tendinosis. It is 2 to 6 centimeter proximal from the insertion. And then comes due to the acute sports injury. So it is at the myotendinous junction. There are two myotendinous junction. One is between Achilles tendon and soleus, and you go above, then it will be Achilles tendon and gastrocnemius. So at any myotendinous junction, there can be some tear, and that can be acute injury. Okay, so three areas can be problematic. Now here, Achilles tendinitis in the insertional area, you can see these are calcifications within the tendon. Okay, here you can see there is some fluid collection around the around the tendon. Okay, so this you can see around the tendon. Now this is called tendinosis. Here there is no fluid collection, but it is 2 to 6 centimeter proximal to the insertion, and here you will just see swelling of the tendon, and there will be loss of fibrillar structure. It will be hypoechoic. This is long axis and this is short axis. Even the short axis is showing the same picture. So this is called tendinosis. Achilles tendon rupture. So rupture is always, I mean, you can see both the ends if it is a complete rupture. But if it is not complete rupture, then also at the myotendinous junction, we can see. So here it is the myotendinous junction. This is actually this area, this black area. These are the fiber of the gastrocnemius. This upper muscle is the gastrocnemius muscle. Some fiber is torn, and these lines, these three lines, these are the Achilles tendon. From here, the gastrocnemius muscle is coming out, and this is the muscle fibers are torn. I will show you the areas. So of course, treatment wise, regenerative therapy, tenotomy, all the things are applicable. So mainly if it is a tendinosis, then you will go for the this one, PRP therapy. But if it is an insertional tendinitis, then you can go for the peritendinous steroid infiltration. Okay. So retrocalcaneal bursitis. So what is retrocalcaneal bursitis? So we have to search the area of the retrocalcaneal bursa. So usually Achilles tendon and bursa, retrocalcaneal bursa is commonly, it is usually affected together. Okay, so both the things cause pain at the back of the heel. Deep aching pain localized anterior to the Achilles tendon insertion, especially with dorsiflexion. So of course, with dorsiflexion of the foot will cause as a stretch to the Achilles tendon, so pain will increase. Then swelling, tenderness, stiffness, pain with activity, redness and warmth, So limited ankle dorsiflexion. So all these things can be there with bursitis. Remember, bursitis is usually acute presentation. Tendinosis can be a chronic presentation, but when there is a bursitis, it is usually a acute presentation. So you can see this is the Achilles tendon and this is the bursal fluid. So if there is no fluid, then hardly you can recognize the bursa. Though 0.1 ml or 0.2 ml of small amount of fluid is common, can be seen in a normal patient also, but usually I mean that is possible in normal patient. Otherwise, if you see if there is bursitis, then only you can see this area. So this is the retrocalcaneal bursitis picture. So corticosteroid injection for the treatment of retrocalcaneal bursitis, there are multiple studies. So I show you the two things first. One is retrocalcaneal bursitis, one is Achilles tendinosis or tendinitis area. Sonoanatomy of this area. Okay. So left side is the okay. So you can see the probe position. So I put the probe in this way. So left side is the cranial side. Okay. So at present, what I can see at present, just a minute. So if I just hold it like this. So somebody tell me, what is this bone? Number one.
Calcaneum. Calcaneum.
Calcaneum.
Hmm.
What is this number two?
Achilles tendon. That is Achilles tendon.
Achilles tendon, fibrillar hyperechoic.
Yes.
Okay. Then comes, what is this number three?
Retrocalcaneal bursa.
Retrocalcaneal bursa, maybe 0.1 ml of fluid. Okay. So what is this area?
Fat.
Target's fat.
Carcass fat.
Okay. Target's fat. Okay. Now I will go a bit proximal. Okay. So this is the, I will increase the depth a bit. Okay. So I'm going proximal. Okay. I'm going proximal.
Gastrocnemius.
No, don't be that in a hurry. So you can see one tendon. What is this? Can you see one tendon?
Achilles tendon.
No, Achilles
No.
tendon is this one.
Peroneus longus.
So remember,
Flexor.
this tendon is either flexor digitorum longus or flexor hallucis longus. This tendon is coming from the medial side muscles. Okay, they come to the medial side like this behind the ankle. That's why we can see this. Okay, from the deep posterior compartment, they come like this. So don't think that this is something about Achilles tendon or soleus or something like that. And this is fat. This is simply fat. Okay, so just see this area. So, yeah, so I'm going. So you see the tendon which I was talking about, that is below. Okay,
Hmm.
that is below. Now I am going up, going up. going up. So
Hmm.
now one muscle has started. What is this
Yes.
muscle?
That is gastrocnemius.
Soleus.
No, so
Soleus,
No, no.
soleus. That is soleus. So this is one myotendinous junction. Okay, soleus. This is soleus, and this is the myotendinous junction of Achilles and soleus. So this one also can have acute injury. Acute sports injury can cause injury to that area. Okay. Now let us go again. Okay, I am starting from here again. Okay, so I'm going again. So this is soleus has come. Soleus, 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 soleus. Can you see one muscle starting above? This one. This is what?
Gastrocnemius.
Gastrocnemius.
that,
Gastrocnemius.
that is gastrocnemius.
Yes, gastrocnemius starts above than the
Yes.
tendon. Soleus is below the
Below.
tendon. Okay. So here actually this tendon is has some portion of plantaris also. But since that is not needed, I am not going into it. But this part is the gastrocnemius starting from the Achilles. So this area, if there is torn, some fiber is torn during playing, that is what we called as tennis leg. Okay, so this is the gastrocnemius. I am coming back. So this is soleus has entered. Now only the Achilles tendon. Okay, now one more thing, that is whenever you do an intervention, then you have to do intervention in this view, short axis view. So this is the bone, Achilles bone, calcaneum bone. This is the calcaneum bone. Then I'm going like this. Okay, I'm going up. So can you see where is the bone and where is the uh, okay, so this is the short axis view. Okay, because you have to do intervention in this view. There is no other option. So what is this? Number one,
Achilles tendon.
and number two,
Bursa.
and number what?
Retrocalcaneal bursa.
Yes, small amount of fluid is there here. So that is retrocalcaneal bursa. And this number three, targets fat pad. And this is the calcaneum, lower part, of course. See again. So left side of the screen. So this is, so it has inserted already on the over the calcaneum. This has inserted. Now what we see is the tendon. See, anisotropy. I can make it black and white. So this is the anisotropy. And now I'm going up. So now actually suddenly bone is very much down. So we can see the area. So you can see one retrocalcaneal bursa area also. Some fluid, some anechoic fluid is there. Actually, I'm pressing with the probe, so this anechoic area is going back. I mean, fluid is. So now the most upper part is the tendon. Now I'm making it black. Okay, black and white. So this is the tendon. Below that, Kaget's fat pad. One small area of retrocalcaneal bursa. We can see this one is the bursa. This one is the bursal fluid, and here is the bone. So in this way, we will hold the probe and your needle has to come in this part, if there is a retrocalcaneal bursal fluid. Of course, this will be much distended. If there is a retrocalcaneal bursitis, then this area will be much distended. Okay. Any question here?
No, sir.
Okay. Let us go to the next part. Okay, so next part is your so plantar fasciitis. So you can see this is the medial part and central part and lateral part. Okay, slips, actually 3 slips are there for this plantar fascia. So plantar fascia, we know it is there in the foot, but all these slips, actually the central part is the most responsible for plantar fasciitis. So, but all these slips, they come to the medial side of the calcaneum and insert there. Okay. So, presenting symptom. So, there are multiple symptoms, but only one symptom which we always ask to the patient, that is first step pain. Patient will come and say that after the whole night sleep, when I get up from bed and I put my first step on the floor, it is immensely painful. The medial side of the foot, okay, medial side of the medial side of the heel. So, and after walking with this pain also, if I can walk say 10 steps, then gradually pain decreases. So that is the presenting symptom of plantar fasciitis. And other, so tenderness at the medial calcaneal tuberosity. You always heals inner aspect. You press and your patient will get too much pain. Now, intensity of pain at the time of presentation differs patient to patient. Okay, so worse with barefoot walking or improper footwear. Pain gradually worsens over weeks or months. So the patient can come to you as a acute problem also, or in chronic with a chronic problem also. So plantar fasciitis, if patient comes with a chronic problem, then of course you can go for intervention. So here we will see here also we will see this is the calcaneum bone and plantar fascia. So how it is inserting in the calcaneum, and we will see this slip of the plantar fascia. Of course, the muscle below is flexor digitorum brevis, so that is not important here. So this plantar fascia, we will see that whether it is hyperechoic fibrillar, and suddenly some area looks very hypoechoic, or the thickness is very much important. So here it is actually 0.83. 0.83, so that is means 8 millimeter. This is more than 5 millimeter is diagnostic of plantar fasciitis. Yeah, plantar fasciopathy. So this is very much swollen. So this is this you can see. So you can compare with this, of course. So this is normal. This is normal, and this is very much swollen. Okay, hypoechoic also. Suddenly one area will become hypoechoic. Intervention. So all this intervention has been tried: corticosteroid injection, PRP injection, botulinum injection, prolotherapy, ultrasound guided dry needling. I will say you go with the presenting symptom. If patient is presenting with the very much acute presentation, then you have to go for the steroid injection. But if it is a chronic pain, then go with the PRP, mainly PRP injection. Okay, I will show the video later. First, I show you the plantar fascia. So I show you the plantar fascia. So this part, only one important thing is, remember this skin is very hard. Skin is very hard. So you have to increase the gain. There is no other way. In your computer setting, if there is a plantar setting, then go for the plantar setting and increase the gain. So I am increasing the gain. So this much. So left side is calcaneal side. Left side is calcaneal side. So after increasing the gain also, it is not that easy to see, and we can decrease the depth a bit. So this is the plantar fascia. So I think you can see well that plantar fascia, there is no swelling. There is no swelling, and this is the, so I hold it like this. So this side is calcaneum. This is the flexor digitorum brevis area muscles. This is the muscles, and this part is, this is the plantar fascia. Okay, so we can see that it is hyperechoic only, and fibrillar structure is also there. If it would have been a plantar fasciitis case, then we will see a swelling with swelling like this. Okay, and this side measurement will be more than 5 millimeter or 5.5 millimeter. Okay, so that we call as plantar fasciitis. You can see the plantar fascia also in a short axis manner. So first let me check in a long axis again. So you can see if I hold like this, so all part of the plantar fascia I cannot see together, but I can show you a large part of the fascia. So you can see from the insertion this, just a minute. Okay, so a large part of the fascia we can see. Okay, so this is the central slip. This is the central slip of the plantar fascia. Okay, this is the central slip of the plantar fascia. Now I will show you the, so you can see the width is normal. It is not like some places has become hypoechoic or swollen. Okay, so this is a normal plantar fascia. Now I will show you the long axis, short axis of plantar fascia. So here also, while intervention, you have to go for the short axis. So I can show you from this side so that you can perceive well. So here, so I put the bone, calcaneum bone in the middle part of the screen. Okay. Now I make it a short axis. So this is the okay. So try to perceive the plantar fascia. This white color, this is the plantar fascia. Okay, this is the bone, and in between this is the black muscle. So this white color, this is the plantar fascia. So when you will give go for intervention, then you have to come a bit more proximally, and then your injection can come below also and above also the plantar fascia. Okay. So have you perceived it well? Anyone have any query? So see the plantar fascia. So this white color, this is the plantar fascia. Okay. This one. Okay. If I go like this, then so this is the long axis. This is the long axis view of the plantar fascia. Okay. Okay. So for intervention, you need to come like this. I mean, you check in the long axis, but then for intervention, you have to put your probe in the short axis, and then you have to do the intervention. Okay.
Sir, excuse me, I have one question.
Yes. Yes.
In some cases, I have seen some calcaneal spurs. How to manage those calcaneal spurs? What to inject?
See, calcaneal spar has been associated with plantar fasciitis, but it is not 100% that plantar fasciitis, I mean, calcaneal spar is the reason of plantar fasciitis, because there are many people in normal people population who have who have calcaneal spar, but there is no plantar fasciitis. There are many people who have plantar fasciitis, but no calcaneal spar. So there is no specific interventional treatment for calcaneal spar as such that requires directly surgery. But I don't think people are much interested, like orthopedicians are much interested to do surgery of calcaneal spar, because after doing calcaneal spar surgery also, pain may remain, since it is not proved that this is the reason of plantar fasciitis. Okay. But if we, someone wants to do a treatment for calcaneal spar, then we don't have any intervention. Our intervention is only for plantar fasciitis, but as such, calcaneal spar will remain.
Okay, thank you, sir.
Okay, some interventions I show. Okay, so this is the tibiotalar joint injection. Sure, you go. So during tibiotalar joint injection, just you have to see that you should not puncture the artery above. Here there is a artery. You should not puncture that above. Okay. That is the, as I told you, anterior tibial artery. Achilles tendinopathy. So this one actually you will find in YouTube this video. Just a minute, I show it. Achilles tendinopathy. So you can see this video. So you can see this is the insertional tendinopathy. This is the area. This is some retrocalcaneal bursa effusion is also there. Insertional tendinopathy, and we did intervention also. So this is a rupture. This is a small mid substance rupture, you can say. So inside the tendon there is a rupture. Okay. So this is, we are doing tenotomy inside the Achilles tendon. Inside there. So this patient actually got very good relief. This patient became all right, and she was suffering for more than 1 year. Okay. Anyway, retrocalcaneal bursitis. This is also in. It is there in the YouTube. We have in your app, there are free videos. You can check your free videos and you can get these videos. So this is the retrocalcaneal bursa. So you can see, so this is the Achilles tendon, upper part Achilles tendon, and this is the bursa. So much of bursal fluid is there. You can go for intervention of the So you can see the needle is going inside. So you have to put a bit bigger needle so that you can aspirate, and then you can put the steroid inside. If you sometimes effusion is a bit thicker, then you cannot do anything. If the your needle is very small, then thick secretion may not come out. Plantar ATFL injection. This is ATFL injection. PRP is being done. So you can understand this side is talus. How do we understand that which side is talus? Remember, talus is covered by a cartilage, hyaline cartilage, that is not there in tibia. So as soon as you see the hyaline cartilage, you know that this is the talus. So this is talus and this is tibia. So this is coming from the, so this is the ATFL injection. Okay. So you can understand that this is between the fibula. This is fibula and talus. Okay, fibula and talus, talofibular ligament. Okay, so this much only. Anyone have any question? You can ask. Otherwise, let us start the quiz.com. So please enter the, just a minute. Please enter the pin. This is the quiz.com. Enter the pin 723296.
Dr. Pig, Mr. Boy, Dr. Clever House, Sim, House Lion, Dr. Danish Aimbot, Lady Cow, Uncle Fork, Slow Quick Man, Lady Woman, Jolly Hyena, Rock Mimo, Toilet Cow, Papa Hacker 1, House Fork, Dr. Lion.
Please join. Nobody's name
Dr.
is there.
Police.
There is no such reason for not joining. Okay, I'm starting the game. Otherwise, it will take too much time.
Quiz.com.
where to join?
Create.
Quiz.com.
Which ligament is most commonly
And this is
affected
the
in
pin.
an ankle sprain?
You write in Google quiz.com.
Jolly IQ joined.
Anterior talofibular ligament, ATFL. What is the primary symptom of plantar fasciitis?
Clever woman joined.
First step in the medial plan to heal. Which nerve is primarily responsible for sensation of lateral force?
Random student joined.
Zural nerve. Which person is located between the Achilles tendon and the scapula? Retrocalcaneal bursa.
Final question. Double points.
Which statement about the plantar fascia's bands and attachments is correct? The central band is the thickest and attaches to the medial calcaneal tuber.
Third place. Uncle Fork. Second place. Lady Woman. And the winner is Dr. N.
So who is the winner today?
Oh, I did not check. Okay, anyway, so I did not check actually who was the first one.
Dr. N.
Anyway, okay,
Who is
okay, then.
Oh no, he is not there.
Anyway, good night. Good night.
Good night, sir. Good night, sir.
Right, sir.
Sir, namaste.